Okay. Oh, that's great. You see that?
Yeah.
Okay. So I've just traced the outlines. I would normally trace a little bit more, but now for our purpose, I've just traced the outlines. So the point I want to know now is what is the midpoint of this face in the orbital region, where the sphenoid bone will connect with the orbits. So I would draw a line here where they cross each other. And I would now measure between the two orbits, that is 38 degrees, so 38 is 15, it's 19. So 19, that would be the midpoint of the face. I would then drop a vertical line perpendicular with the face. Perpendicular to that baseline. And now I want to look at where's the asymmetry. Is that the patient that we see that we saw there?
Yeah.
Is that the one?
Just
Because to me it looked like he had a big canter. I'm not sure where the tooth is here. Now the important thing here for us is that it looks like the dental midlines, his occlusion is already aligned. So the midline, I don't want to disturb the midline, but I can see according to the clinical that to me there's a bigger cant on that clinical than I saw on the that I see here. You see that the cant is not that big, and I'm looking at the gonial angles. I can measure it there. I can look at it there. I can look at the antigonial notch. So let's see there. And I look at the chin. There's the point there and the point there. And we'll do it like that. So we can, and then I will draw a line there and there. So we can see here, we see a bigger cant. So now I can do my triangles like we did on the slides. I'm doing it very fast so that we not waste a lot of time. And I'll go here, about there, it looks okay there. And we do it there. And there. And here. So now we can see our triangles there, and we can see that there's a cant. Interesting, I'm not sure about the teeth. Has he got? Yeah, I think this is, not sure about this area here, because that's where he's got an impacted upper molar. So I'm not sure where this actually is. Maybe it's a little bit higher, but we're doing this just for explanation. So if I need to know now what's the difference between them, I would drop a vertical line there and a vertical line there, and I can measure and say this is 71 and this is 70, what's it, 77, about 7, yeah. So we can see that there's a substantial difference between the two. The important thing that we spoke about this morning is the tooth position of his upper incisor. And I was just looking, he's showing, when he smiles, so we're going to smile there, or when he's relaxed, the upper incisor is vertically in a good position. So when I do the cant, if I'm going to correct this cant, just hold it like, if I'm going to correct this cant, I can do it by doing it this way, by dropping it this way. I can do it by moving it that way. Now can you see what happens where the tooth is. If I'm going to I'm going to rotate around this area here, I want to correct that. You see that the tooth will shorten. That's the first thing. If I'm going to downgraft only on this side to get the cant corrected, the tooth will lengthen. Okay? The other important thing is, if I rotate, the midline is going to shift to the point, to the fixed point. Let's take an example. I'm going to use it like this, and this is the midpoint of the incisor. Now, if I use this and I'm going to downgraft on the one side, look where the midline's going. It's going to the point, the rotation point. So I'm going to move the midline. So if ever you correct it, you've got to keep the midline in the middle of the face, unless you want to change it. And you know, at the time when we do the surgery, the contact point in the maxilla up there, if we use that as we need to move it across, off the contact point, a little bit to the left. So I would now decide, there's a big difference skeletally, but I think dentally, I can't see the teeth that very well, but I can now see what's the discrepancy, and I can also measure that on my models, what the discrepancy is. Let's see. The cant here, it is 95. And here, not much more, 97. 97? Yeah, it looks like it. So the difference here is 4, yeah, 3. It's only 2. I think it's more, but let's take it's 2. So because I want to keep this point exactly where it is, I don't want to change the vertical, and I don't want to change anteroposterior. I would, because the discrepancy between the two is, let's make it easier, say it is 4. I would come down 2 here, and I'll go up 2 there, and I will make sure that the dental midline is in the middle. Maxilla will tell me. If I've got that asymmetry, I correct the cant in the maxilla first, because it's definitely the easy. To correct the cant in the mandible, it's possible, but it's more difficult. And I can do it in the maxilla more accurate. So once I've done that, I can draw in on a red line the correction of the cant, and I do the correction on the mandible, and I can see, I can draw my sagittal split osteotomy on this side and on this side here, and I can see how much the mandible needs to move. And important thing for me here, you'll see here at the bottom here, it looks, I can measure it, the difference, this is 36, it's 15, it's 16, there, that's the middle. So I'm very pedantic here that the midline's a little off, but keep in mind that if I'm going to correct the cant of the occlusal plane, the mandible is going to move that way, and the chin will also move that way. So I expect this chin to be in the middle. But say now we have a case where the midline is there, then it will tell me that and the dental midline is there. It will tell me that I may have to do a genioplasty and move the chin across to get it on that midline. Easy.
Thank you, Professor Reyneke, for describing this interesting method. I want to ask a question. Do you ever plan your surgery according to only this planning method? I mean, without surgical guides or other methods?
No, what I'll certainly now that I know what I'm going to do, say for instance, I'm going to move the maxilla down on the one side by 2 and up on the other side by 2, and I want to keep my model surgery will now be done like that, and then I do my surgical split. Now in this case where the patient has
Можно переключить картинку с компьютера.
So I would do the maxilla, make sure that it's in good position, do my measurements, my model surgery according to these. Now remember that this 97 is not going to be the same on the models. But when I do my model, I articulated the models, I expect that I'll measure the distance, the vertical distance to the ring of my articulator, like there, and I see it must be very close to the two. Then I do that surgery, and then I make an intermediate wafer. Once I've done the maxilla, in this case, I would. The occlusion is fantastic. Am I right?
Yeah.
I'm not going to do a final splint. No, no, that's easy.
And may I ask one more question? Would you place a screw in glabella point, like a landmark?
For control.
For control, yes.
Yeah.
Measurements.
Yeah, I
Thank you.
possibly do that. Yeah, but whenever the case, this is quite an easy case. If I need to, for instance, do segments and stuff like, I'll certainly today I'll go 3D. I'll go with the scans. But this is not a very difficult case because it's the nice thing about it. He's got a fantastic occlusion. His occlusion is my guide. I just take that. Remember my triangles. So basically, I'll just do this. Finished. The important thing for me in this case is incisor position. Because if you do this and you correct it, the incisor tends to go towards the side you shorten. So make sure if you do that, bring it back to the middle.
You have just told that it's not difficult case, but I operated him twice, and we discussed about third attempt. This is post-surgical X-rays. We perform bimaxillary surgery, and I tried to control the occlusal cant. And with occlusal cant, we have not a problem. We checked the occlusion. We didn't use the braces because the occlusion was perfect, and we. Что я на английском-то, господи? Я думаю, что мне так неудобно. We checked the occlusal contact. We corrected the occlusal cant, but you can see some problems with asymmetry at the left angle of mandible. I performed second step surgery. We removed mini plates, and I reduced external cortical bone at the left side. No changes with occlusion, but we see some asymmetry with angle. We can check the changes of bone after this surgery. We can see minimal defect of bone at the left side, but I hope it's not the full defect. I hope it's spongious bone and it's not visible at the 3D reconstruction of computer tomography. And changes of face before, after ortognatic surgery, after bone removing. Now we discuss question about masseteric muscle reduction, and maybe we will perform it because at the start he didn't have a lot of question about his aesthetic aspects. Now the level of his wishes increase and increase with time because I think he has a nice result, but he would like to look better.
Sure.